Good morning, everyone. Welcome to Pediatric Grand Round. Thank you for joining us online and in person. If you are anywhere near the Mill Mountain Conference Room at Tanglewood, please come and join us. The lecture is really meant to be interactive and in person, and we have breakfast today. I think there's donuts and coffee.
And bagels.
And bagels. Wow, we're going all out today. So please come and join us. Today's presenter is Dr. Camron Johnson-Privitera. She completed her medical degree at Philadelphia College of Osteopathic Medicine and her residency at Geisinger Medical Center in Pennsylvania, where she served as chief resident and pediatric hospitalist. She spent the last 20 years as a pediatrician at Physicians to Children. She's an assistant professor at VTC SOM and VCOM. She obtained her IBCLC training in 2019, and she's a fellow of the Academy of Breastfeeding Medicine and board certified in breastfeeding medicine. One of the few, if not the only person in Rona?
Yes, in Southwest Virginia.
In Southwest Virginia. She currently serves as the Virginia AAP chapter breastfeeding co-champion. Please join me in welcoming Dr. Camron Johnson-Privitera.
Good morning. I'm super happy to be here. This lecture stems from a couple things, specifically residents and students who have come in and rotated with me who have said they really wanted more practical approach to managing these patients. The breastfeeding dyad is really two patients that need to work in cohesion to be able to make some things happen. And you are going to see these patients both in your clinic, you're going to see them in the hospital when they get readmitted through the ER, to the floors, or to the NICU. And so I hope you take some good information from this, and I'm always available to help if you have questions. So right off the bat, I am short and can't see over this well, so if you cannot hear me with the microphone, please let me know. Okay, first off, I have no conflicts of interest to share with you, and we're going to go over a couple things. So first things first, this is case-based. I'm going to ask for your interaction because that's how people learn best, by kind of talking through, not just me spouting off facts for you. And with those clinical cases, we're going to go through both the anatomy and physiology of some lactation that you will need as basic knowledge to kind of troubleshoot the issues. And then we're going to look at some of the protocols and the research behind them. I'm not going to give you research studies because the research is included in those protocols. These are newer things that have kind of come to light in the past 5 years. And I want you to have those resources as you need them. And then I'm also going to talk about some specific things in the communities that are working toward supporting that breastfeeding dyad with resources that you have access to as a general pediatrician or a subspecialist pediatrician. So let's get started. First case is about a 4-day-old that presents to the clinic for a weight check. This is pretty typical right after the hospital discharge. Mom says she's having significant pain with attempts to nurse, and the baby is crying when she tries to put her to the breast. She's had 2 wet diapers and 1 stool diaper in the last 24 hours. And on the exam, the vital signs are fine with the exception of the baby's weight is down 9% from birth weight. What do you want to know? I'm going to pick on you if you don't.
I would ask about latching.
Okay.
Just kind of how is she latching? Does she feel like she's getting a good latch? Is it deep?
So the answer was she wants to know about latching. What does it look like? Is it deep when she gets onto the breast or not? Okay, it's a great question. Anything else?
What's the interval? She's taking the volume, and she's feeding overnight as well. We cannot feed.
The schedule of feeding is a great way to do it. With breastfeeding, there's no way to know volume. So the volume is really in time, right?
So how long?
How long is she staying at the breast, which is a great question. And that latch, is it effective? And is she hearing the baby or seeing any changes? What about mom? Any questions about mom?
I would like to know how her anatomy is looking.
Oh, good question. So what about, the answer was, the concern was about mom's anatomy and how does it look? What would you be looking for specifically?
Well, how big her breasts are,
Okay.
look for inverted nipples.
Okay, the inverted nipples are size of the breast. You were gonna add something?
And nipple cracks.
And cracks or trauma to the nipple, right? Really good questions. Those are part of your physical exam. What history do you want to know? Any pregnancy history?
Is it the first pregnancy? Has she had any other babies? Has she breastfed before?
Yeah, so what is the her para and gravitas status? Has she previously breastfed? Any complications with the pregnancy that you may want to know? Anything in particular you would be worried about?
Previous mastitis, previous like her.
She's a 4-day-old, so mastitis probably wouldn't be in that right there.
It was maybe like in previous pregnancies, but previous breastfeeding.
I see. So you can have mastitis outside of the lactating patient, right? So men can have mastitis too. So your point is a really good one. So she's asking for traumas to the breast, whether it is an infectious cause, but you can also have surgeries, right?
Yeah.
So did mom have any problems with a previous injury or a previous surgery to the breast or nipple piercings, which can make a big difference?
Was the baby like born at term? Did they have any issues in the nursery?
So questions related to the delivery process, right? How was the baby born? If the baby is preterm or on time, if there's any complications related to the delivery itself that would put mom or baby at risk to not be able to be alert or make those changes. So really great foundation. Let's move on and do a little bit of some of the background of how breast milk is kind of developed. So lactogenesis is kind of split into 3 phases. The first one is all endocrine based. It's all related to the hormones that are released during pregnancy, starting first in puberty with the development of the breast ducts, and then differentiation in the ducts as well as the alveoli, and then the alveolus that actually creates the milk itself. And all that happens during pregnancy. So that pregnancy environment is really important. If there's significant issues that would potentially impact with that endocrine feedback loop, we need to be aware of that. The progesterone and estrogen levels climb pretty quickly during that pregnancy, and then toward the end of the pregnancy, the prolactin level usually is above that suppressive dose of the progesterone that is naturally there. That's why women will sometimes have leaking at the very end of their pregnancy, because the suppressive effect of progesterone on prolactin is superseded. At delivery, the estrogen and the progesterone levels crash with the delivery of the placenta. But what if the placenta isn't completely removed, right? So part of that delivery process becomes really important, right? So that progesterone level is considered to be the primary suppressant to prolactin, but estrogen plays a role, and that drops significantly, and then the milk comes in. Any idea when that happens?
So like 2 days after birth.
Ish, right? So typical time frame that we see the breast milk come in for first-time moms is usually between day 3 and day 5. If they've already breastfed, it can come in a little bit earlier, but all those complications that we just talked about can play a role in that, right? So typically lactogenesis 2 starts when the milk comes in, right? That fullness that they feel, the milk starting to leak, baby starting to be able to transfer that milk. And then after those first 2 weeks or so, the breast milk stimulation changes to an autocrine control. It is all based on positive feedback loops from pulling. If the baby's not pulling, mom's not emptying that breast for some reason, the milk supply will go away, which is why it's so important to make sure that we are having a consistent process with latch and removal in those first 2 weeks of that breastfeeding experience, so that you have a good place to start.
I have a quick question.
Please.
Is there any difference in the production, the initial production, with babies that are born via vaginal delivery versus C-section?
Ooh, really good question. So if I understand correctly, your question is there a difference between when the milk comes in, whether they're a vaginal or a C-section delivery? In general, yes. The C-section deliveries tend to come in later, but any complication related to that delivery process can make the milk delayed too. So if mom is super hypertensive or has a big hemorrhage, all of those things can interfere because the body is stressed. And we're first going to try and, the body first puts all energy to saving mom, and then secondly to saving baby. Okay. Really good question. Here's that feedback loop. So the anterior and pituitary play a huge role, and if there's, again, complications related to pregnancy and that pituitary gland gets hit, you can see a significant change in breast milk production and release. So when baby's at the breast, there is a positive feedback loop to the brain, the hypothalamus, that suppresses dopamine a little bit and stimulates the anterior and posterior pituitary. The prolactin is produced in the anterior pituitary. It's what makes the milk, okay? And the oxytocin released from the posterior pituitary is what releases the milk. It tells the milk to kind of get released from the mastocytes. So, and the ducts itself, that's the letdown, that's the discomfort that moms will feel. And remember, that's the same thing you see with postpartum delivery. That's the oxytocin release as the cramping of the uterus is happening. So you can see a lot of women will describe, whenever I have a letdown, my uterus cramps and it's really uncomfortable. Great, we're shrinking that uterus right from the get-go, right? But the progesterone in the placenta still plays a role. That's where we were seeing that negative feedback loop during pregnancy. And then post-delivery, if there's any remnants of, or if there's any complications in the other endocrine systems that we need to be watching for, is the adrenal gland affected? That's your question with the C-section or the hemorrhage. If there's any insulin resistance or the thyroid is not doing well, there's all kinds of pieces that go into that. And you need to keep that in mind when you're looking for why is this baby not gaining, right? Big risk factors for insufficient milk production. At day 4, so remember, and it's day 4, we don't have a great way to be able to say which one that is, but these are the things that you should be looking for, right? And you did a great job of pulling those out when you're going to look for this, the etiology for this. So what's mom's age? A 30-year-old is going to make more milk than a 40-year-old usually. If there's delivery complications, chronic health problems, is mom hypertensive at a baseline? Is she a type 1 diabetic, right? If there's any history of infertility or PCOS or some metabolic disease, then we need to be keeping a close eye on that because that can make a big difference. And I've seen thyroid do crazy things, both in terms of increasing and decreasing milk supply. And the other piece related to what the breast size looks like is that insufficient glandular tissue. So some women just don't create enough of that duct differentiation and alveoli differentiation in their development, both in puberty and in pregnancy. There are a few things that we know that can cause that. I'm not exactly sure why some women do and some women don't. So a little bit more history. She was a 38-week spontaneous vaginal delivery born to a 34-year-old mom. This was a pregnancy that mom and her partner conceived by IVF, and mom's past medical history is only significant for a BMI of 30. So she doesn't have a huge list of things that would make it difficult for her milk to come in, okay? Which is a great foundation. She still doesn't have enough of a supply yet that we think because the baby's not gaining, right? So now we're left with, is this latch? Is this transfer, right? So baby can get on but not pull it out, or is this supply? That's still where we're at, okay? Mom is worried. She was on TikTok, and there's all these TikToks and social media, Instagrams out there, and they all say that the baby's got a lip tie, a tongue tie, and a buckle tie that make it difficult for the baby to latch. Everybody's smiling here. I see several interns, and I know you've probably already seen this, right? That's the biggest concern, is that there is there's something anatomically wrong with the baby. Okay, so we talked about your history. Your physical exam becomes really important, right? So you want to look at mom. You want to look at the baby because you're looking for anything else that can play a role in not being able to latch, not being able to transfer. Is the baby super dehydrated and not awake? That's going to make it hard for them to feed, regardless of whether it's a bottle or a breast. Is the baby hypothermic? Those babies don't feed at all. Do they have any dysmorphic features or trauma on their body? One of the most common reasons that we'll see, I shouldn't say that, a common thing that we need to be caring for and watching for is if there's a cardiac abnormality and the baby doesn't have the stamina to be able to latch and transfer. So it shouldn't go straight to tongue tie, right? Looking for the motion and the movement of the head, any abnormalities with bruising or even some plagiocephaly related to birth trauma, and then look at the tongue motion. For mom, you're looking at, is mom really stressed? Does she look bad? And there have been times when I've had bit moms come to me and I say, we're not doing any of this with breastfeeding. You're going and looking at your OB because your blood pressure is high, you've got a bad headache, you've got sunglasses on. We're not doing any of this. We're going to get mom in good shape, right? So you need to be aware of that part too. The shape and contour, the nipple shape or injury, like we talked about. Really good job. All right, short segment on tongue tie because this is the hot topic right now, and I want you to get some good information on how to assess this. On the left-hand side, I think that's your left, is what we want to see when the baby's crying. So we should be able to see the tongue go up, flip up in the front anteriorly, as well as on the sides. If that baby is latching well, they grip onto the nipple and pull. There's no sliding, there's no friction. It should hold on tight, and if you put your finger in the baby's mouth, you don't want to put it just behind the anterior ridge of the gum ridge on the top. You want to push it back a little bit. I usually can get about 1.5 inches in there, and the baby should be able to hold on. It's almost hard to get your finger out, right? If they can't hold on, that makes you wonder, what's going on? Is there something else here? And then looking for that motion, which is super important. The ankyloglossia is one of those things that we have always seen, but has really, the diagnosis of this has just exponentially climbed. And there's a lot of different strategies to classify the different stages of the tongue tether. There's a lot of classifications to look at mobility. None of them overlap. So depending on which group you look at, whether it's the ENT or pediatrics or pediatric dentistry, and the idea that I would tell you to do is get used to doing your exam over and over again so that you know what you're assessing, okay? This one, the tip of that lingual frenulum is tethered to the bottom of the mouth as well as to the tip of the tongue. And you'll see a scallop in the tip of that tongue. Baby can't push that tongue past that bottom alveolar ridge, right? You also want to make sure that baby can turn the tongue to the sides, right? They should be able to have enough mobility in there that they can clean the teeth and the molars. They should be able to have enough mobility in there that they can then push past the alveolar ridge to be able to make a TH sound and grip the tongue. The breast. So we don't necessarily need to clip every single one of these. Sometimes, just with a good latch position, you'll see a stretching of that or no pain. So the key is the functionality of that tongue motion and transfer of milk is affected, not necessarily the way that it looks. This is what a tongue tie or a tether does to the latch. So on the left, you can see that's a normal attachment where the baby is deep on, nose, upper lip, chin, and lower lip, all up against the breast, and wide open mouth, right? With the nipple areola complex, the protrusion part is pushing all the way back, and ideally you'll have the tip of that nipple posterior to the hard palate ridge where the soft and the hard palate meet. And you should be able to feel that on your finger. So if you're going and you're feeling that baby's gagging and not tolerating that well, it makes you wonder what else is going on in here that they're having a hard time. But if that nipple is at that soft palate, it doesn't hurt. versus when it's a little more anterior and either right behind that alveolar ridge or on the hard palate, it gets pinched. And you'll see the line of sores or scabs on the nipple in that line where they are pinching at that nipple. So mom has lots of maternal pain, and they don't transfer that milk very well because they're not actually getting to where the ducts are releasing. So when you're helping moms to express, you're not pushing on the nipple itself. The nipple areolar complex won't release that milk very well. You'll get a little bit, but if you go way deeper past onto that breast tissue, you'll actually have a lot more expressed with just that same motion. All right, so we talked about looking at the parent and the child. We talked about looking at the latch. Really important to know what a pre and post weight is to that feeding, because it'll give you an idea of how well that baby transferred milk. There is no such thing as a time to breastfeed. So we don't follow minutes. I know that's what we track, but it really is about the transfer of milk. And some babies will get all that they need in 4 minutes flat. I have other issues about that, but I'm not going to go into that today. But that 4 minutes flat could potentially be exactly what that baby needs. And it may be that that baby who nurses for 25 minutes gets exactly what they need. It's not about the number of minutes. It's about the effectiveness and the pull and the transfer. So the only way to know that is a pre and a post weight. Okay? You're also going to look for the alternative etiologies like we talked about. And then the frenotomy considerations are something that I just want to make sure that we have the opportunity to talk about. You need someone who knows what they're doing to look at the tongue and to look at the latch, and as well as to be comfortable with the procedure. The procedure in general is pretty well tolerated. There's a few side effects that you need to be aware of, but not everybody is going to be comfortable managing those complications. And you don't want to have someone who's unfamiliar with what that looks like. And I also don't love the idea that there is someone who is addressing the lingual frenulum and then not helping the baby latch immediately. Because the key is the latch and the change in the motion. So I don't think having them, many years ago, people would drive to DC. There was a dentist in DC who would take care of the lingual frenulum, and then they would drive back 6 hours to be seen the next day. Well, that's not really a great source of treatment for the baby. And the only thing I'm going to say about the stretching is there's not good data. And depending on who you ask, you'll get different thoughts on whether we are swiping that wound. I have big concerns about putting a finger over top of an open wound as it's healing. Now I worry you're going to have more oral aversion, but you're going to have other people who swear by one way or the other. It has to be done this way. It doesn't have to be done this way at all. You probably aren't ready to make that decision. I personally don't stretch if I can get the baby to the breast. That anterior protrusion of that tongue, I think, is enough of a stretch. And I have not seen any of the reattachments after a frenotomy. Okay, here's some data for you. The most recent one came out in July. It's the AAP policy statement, and it is free. The link is there. Help yourself to go and look. It talks about all of the pearls and pitfalls on how to be able to assess this and making sure that babies are getting the good care that they need. The Academy of Breastfeeding Medicine has one out as well, looking at, and they pretty much say something similar in terms of management and evaluation. The otolaryngology consensus statement was fascinating because they really went through all the different scoring models, all of the different evaluations for the motion and mobility, and there's not a lot of consensus. On some things they were hard and true, and some things they were all over the map in terms of what was needed, including the swipe or not swipe, stretch or not stretch. There is no data whatsoever that says the frenotomy with cold steel or scissors versus a laser is better or worse. You'll have people that are very married to one or the other. I personally have seen way too much heat injury and oral aversions for babies that have had, I see lots of people nodding their heads. Most of the pediatric, I should say most of the breastfeeding medicine physicians and the pediatric ENTs that I talk to prefer the cold steel. They do better in terms of immediate ability to latch without that pain. And watching your child who just had this procedure, who has swelling of their mouth and their face because of the heat injury and avoidance of food when we were already in a place where they were struggling to gain weight is really hard because they don't take anything. Bottle, breast, cup, it's hard. Okay, so we're going to talk a little bit more about assessing the latch and what this looks like. What should you see? There's a great video. Global Health Media Project puts together these really great, depending on the topic, 5 to 10 minute videos. This one, the first 3 is really what you want to see, and it talks about the mechanics of the latch, both on the outside and the inside, and how to get the baby on. I love it because it's all different nationalities, and so it's not programmed specifically for Southwest Virginia. You can use it for everyone, and there's a ton of different languages as well, which is fantastic for our population, especially with the immigrant population that we have in Roanoke. I actually have this to share with my patients in the office and at home because it's so helpful for them to be able to see it, right? In general, what you're looking for is the baby to be belly to belly. I want you to imagine drinking from a straw like this. It's not comfortable, right? Drinking from a straw like this. It's not, you can't get as big a bolus and you can't transfer as well. And if the goal is to get that nipple way into the back of that mouth, where we're off of the hard palate, this makes it difficult to do, right? So chin up, right? We say sniffing position. Belly to belly, straight on, not twisted. And you want the baby's ear, shoulder, and hip to be in a straight line. So if they're twisted, it makes it much more difficult to use those symmetrical muscles in the neck. Right now their tone is not great. Eventually when they're 2, they kind of hang on upside down. We call it toddler gymnastic nursing. And they're all over the place, right? But that's not what this new baby is doing. They really still need that support to be able to get on there. The other thing that you're looking for is that audible swallow, and somebody said that really early on. You want to be able to hear them transfer. It's very clear when they do it. It's a sound. And you can actually see as they're swallowing, their suckle changes. So when they first are going on, they're going pretty fast, right? Stimulating that breast to kind of get going. And then once the milk starts to release, if they've got a good latch, it slows. It's deeper, it's wider. You'll see their jaw open. You'll see the neck muscles move in a different direction. And I say that in a very vague way because every kid's anatomy looks different. If they're skinny, you can see it differently than when they're fat and chubby, but it looks like they're using those muscles in their neck a little bit differently. Some people use the ear. I don't find that one as helpful, but you might get used to looking, okay? The bottom lip should be flanged open like you can see here. Does that work? So the bottom lip here, the top lip really just acts as a flange. So we didn't even talk about the labial, the maxillary frenula here and the buccal size. Those are all normal structures. Every single one of them is a normal structure. So the key is it causing problems? This one, I rarely see cause an issue. I've been doing breastfeeding medicine I've been doing breastfeeding with moms for a good 15 to 20 years and really started getting more involved in the last 10. But I've seen this labial frenulum cause an issue twice. And they were 4-month-olds where mom was still just having pain. Baby's doing great. Mom just said, please, let's try something. But babies who have a cleft lip can nurse just fine. You don't need a seal. You just need it to lay there. So the idea behind that tether, I'm more worried that they're too shallow on the breast. They're further here and they're using those perioral muscles to hold on. And they get tight and they're pulling, and you'll actually see the friction bubbles. You've seen the breast milk blisters on the mouth. Those I worry because we're doing some friction, not because we're not, we don't have an anatomical normality. I've had several ENTs here at Carilion who have had babies get sent to them for a tongue tie release, and they say this is not a tongue, and they send them to me and we can fix the latch. And it goes a long way. And parents, for the most part, don't want to do a procedure on their baby. They want their babies to feed. Close follow-up is key. So For Allison, all it took was repositioning her. She was in a position where her head was down and tilted to the side because mom was trying to bring her to the breast with her arm. Works really well when babies are little to use the back of the head with your hand kind of cradling the occiput in the lower neck, upper neck, lower occiput to bring the baby in to the breast. And she was using her arm, so the baby ended up folding down and she couldn't get the baby on. So in that scenario, just getting the baby positioned well was able to get the baby on and transfer milk in the office, right? That was a huge impact for that mom. You can make a big improvement both in the feel as well as their confidence in being able to do it at home. And you can see a release from the breast. It's not as uncomfortable. So mom's milk was in at that day 4 mark, but she was not transferring it, and that's why the baby was down. So close follow-up becomes key. That baby at 9% down with a mom who hasn't been nursing well, I'm seeing the next day. I don't usually supplement that at that point because I've seen the milk coming in. I've seen that we can get the baby to the breast, and I actually have moms redo that latch over and over again in the office to make sure that she feels confident doing it while she has somebody there to help her. In general, you want to see that weight gain, and you know this, 15 to 30 grams in a day, right, over the next couple weeks, and then we want them back at their birth weight by 2 weeks of age. Sometimes if we haven't had a great start and then we start seeing some progression at the end of that week and a half or so, they're not quite there, and I continue to follow them until they hit that mark and we're on a good space. That was a lot, yeah.
So you said earlier that the best way to know if the transfer is happening is to do pre and post feeding weights. Is that something you do in the office? Because obviously the parents are not going to be able to do a very good job at home.
I absolutely do it in the office because that is part of my assessment of if this baby's transferring. It's how I'm kind of differentiating where in the space do I need to be looking. There are some parents who really want to know how much the baby's gaining. I think that's a stressful way to do it. But some parents find comfort in knowing that their baby is gained, and then I give them very clear markers on when to do it. I don't tell them to go and buy a baby scale. They're really expensive. But the kitchen scales that you can get, they're like $10 or $15, right? Those digital scales. I don't need a medical grade, right? And then I tell them to get a cute stock pot or a basket and put it on there. It's adorable pictures one day, right? And they can, and then I give them a very specific time. You should be measuring like a weight first thing in the morning or at the lunchtime hour. So it's about the same time that they're doing it. I don't ask them to do pre and post weights because it's just stressful for them. I'm doing them, right? I want to see how much did that baby transfer in the office because it helps me as I'm trying to figure out where we are on that continuum of the ultimate cost. Yeah.
Not to get too practical, but how do you manage time with regards to these? So, and then the other caveat is billing. So I know obviously when you do a weight check, you can then bill for your time, but if this is like your newborn well check, are you then billing on top of it for time? And kind of logistically, how does that work out? Because especially those weight checks sometimes get put for us in like 10-minute slots, and then it's really hard to triage breastfeeding.
So I have weight check slots that are, say, 10 or 15 minutes, but I also have breastfeeding slots or lactation slots that I typically have built into my schedule that is usually somewhere between 20 and 30 minutes. The first time is always 30 minutes, and there are lots of times I will walk out, see another patient, come back and check. So those patients can be there an hour. So it is one of those things that it makes such a difference in the life of this mom as well as the life of the baby. And I did not go through any of this in my lecture today. I've done it before, but the long-term benefits to mom, both in the short-term period, that first year, as well as her lifetime, are pretty significant. And we know very clearly the lifetime benefits to the child is pretty significant as well. So it's worth putting that time in as far as I'm concerned. And my patients have figured out a long time ago that I'm not going to be on time. And I've had people tell me, I know you'll spend the time with me when it's my turn.
Yeah.
And that's the kind of medicine, that's the kind of physician I want to be. So billing, you are reimbursed based on your level of involvement and care. And so these are not 992 and 3s, right? So they are they are paid, period. You're a physician, you should be able to bill for your time and your expertise. So, I always see them back at that 2-week mark, going back to watching that prolactin level fall and switching to that autocrine control. I want to make sure that we've been able to not just live on that letdown. That milk is coming like crazy in the beginning, but now I need the baby to pull, and if the baby's not pulling, I'll see that first sign at that 2-week mark. And sometimes it's, oh, baby's doing great, but they sleep 8 hours at nighttime. I want to know that at 2 weeks, not at a month, right? So, all right, really good questions. Any other thing else before we go to our next patient? Okay, the other ones are not as long as that one. This is a 3-month-old male who's growing well. Mom is exclusively pumping. She's noticed significant pain in the breast and much less milk production in the last 2 days, and as she's seen less milk production, she's seen more increase in her pain. She hasn't had fever, but she has some redness at the breast. You can see the difference in the volume of milk that she's pulling from her pump. What do you want to know?
Is she breastfeeding other than pumping, or?
She is not breastfeeding at all. She does not. Mom has some anxiety, self-proclaimed, and she wants to know exactly how much that baby is getting. So her choice was to exclusively pump, and she has done well for 3 months. Great question. Really good question.
How is she pumping? Does she pump both breasts at the same time? Does she do one and the other? What is her?
So the question is, how is she pumping? So she's doing a double electric pump. She uses a pretty good pump. She's using a Spectra that she has already had fitted. She used it for her previous child. It's worked well. And she normally is getting good volumes when she is pumping. She has not done the hands-free version at all. Why is that important?
They're not as good at extracting the full volume.
So the hands-free pumps, to reiterate, the hands-free pumps are harder to fit. And so sometimes they don't get as good of a suction, and they don't get as good of a seal, I should say, not necessarily a suction. Because when you measure the suctions, they can be just the same. But sometimes the seal isn't as good. And then what happens is they don't end up pulling as well and as much for some people. But that's important to know. So good that logistics of how we're making that happen is good.
Was she fitted? Was she evaluated during this during this child's for the size of the flange, or was it the previous?
Yeah, that's a really good point. So knowing, because the breast changes
a lot.
The nipple areola complex looks different, child 1, 2, 5, 7, right? So making sure that it's a good fit. She has had it fitted before. I did not see this fit, but she was told that it was fitting, and for 3 months it's been good.
A little bit more about the pain, like is progressive? Does she have like a fever? Is it warm? And like a look for mastitis there?
Yeah. So trying to see if we can figure out if this is a mastitis picture. So I can't remember. I'll get to that in a second. So the question was, what does the breast look like? Is it hot? It is warm. It's a little bit red. It is becoming more and more tender in that area of one breast. And it is a little warm to touch, but not awful. But the biggest complaint that she has is the whole breast is sore. That's important to differentiate between the nipple is sore, right? So the whole breast is sore.
Has she tried anything like massaging the
Good
breast?
question. So the question is, has she tried massaging the breast? And Mom said, yeah, she's been trying to push because it feels hard on that area, so she's been trying to massage that area out.
Warm compresses and things like that.
She was using some warm compresses as well. No, it's not helping. All right, so I want to do a little bit of the anatomy of the breast. So you can see how closely that tissue sits right up against the pectoral muscles, both the inferior and the minor and the major, and how intricate those blood vessels are in feeding those lobules. So you have the lobes of the breast, which consist of multiple lobules. So the lobules then condense into a lobe that then enter and exit out through the ducts here, and then out through the nipple areola complex. Nipples look different. Some of them are flat until they start getting stimulated, and then they stand out. Some are flat and don't look like they get stimulated, they pull out and become erect. but the baby latches fine. Some stand out at all times, right? The important part here is how close the blood vessels, and what you don't see on this picture is the lymphatic drainage that's on here too. The lymphatic drainage is actually pretty small. It is actually only on the lateral edge of the breast itself, and so when you're massaging to try and help, if you can invoke kind of that pattern, because the lymphatic drainage drains here to the subclavian vein. So if you can get that tissue to kind of sweep up as you were massaging gently, you'll get more decreasing the engorgement and the swelling. Beautiful picture that was done. You can see how the lobules will kind of dump out of the nipple, and they almost form like this super highway, right? Everything's coming in from all the exits down to the 81 and then out through the nipple itself. You can see the alveoli, which is the big cluster, and then the individual cells are the alveolus, and then in the bottom left-hand corner, bottom right-hand corner, the lactocytes, which are epithelial cells. Those lactocytes are actually what makes the milk, and they form this nice lumen in the center of there, and they get distended when the milk gets full. So it gets collected into that, and then when the oxytocin is released, the muscles around that will squeeze it out and down through the ducts. So the individual cells, so there's thousands and millions of these things that sit, and there's multiple processes in developing that milk. So that milk gets kind of created in real time in response to maternal illnesses and maternal nutrition, as well as babies' feedback to the breast. A very short little segment into this. There are lots of lipids lipids make up probably the majority of the milk itself. There's oligosaccharides, which is a human milk oligosaccharide. You see it in all the formulas. It's not human milk saccharide, it's bovine milk saccharide that's in the formula. But human milk saccharide is very specific to humans, and that oligosaccharide has really good properties in terms of feeding the gut microbiome. The antibodies are primarily IgA that are released, and in direct response to any exposures mom has had previously in her pregnancy or her lifetime or current illnesses. And there's some evidence that babies can actually stimulate mom's breast to make specific IgAs to illnesses that they have. So we know that babies who are in daycare and breastfeeding do better with the colds than the babies who are getting formula. They have less ear infections. They have less lower respiratory infections. They tend to manage their weight better and that we think that is related to mom's immunoglobulins that are being passed, as well as that immediate response to any exposures that the baby would get just from the antigen being expressed through the nipple. I see some crazy looks out there. People are going, what? That's real? It's real. Okay. I don't know what I'm doing here. So I love this picture because it really gives you an idea of how closely clustered those lobules are, and all the alveoli sitting close up to one another. And when they get distended, they push. And that can cause some, number one, discomfort. Think about when your belly's full of gas. Your belly's full of gas, it hurts, right? So that distension can cause issues. The other thing is that there's not a ton underneath of that breast tissue. Once you get past that fat layer, all you have are the lobules. So if you're pushing really hard, you're going to damage that tissue, right? So we don't necessarily want to rub the thyroid when the thyroid isn't making enough milk, enough of the TSH and enough of the T4. We want to kind of leave that alone because you can cause trauma and swelling that's there. All right, so answer some of those questions using a spectra, and she had been trying a hands-free pump intermittently because she was out and running about, but that was the only thing she had done that wasn't very different in the past couple days. Typically, she makes about 45 ounces of milk a day. Is that good? It's a lot. I see a couple people saying, oh yeah, that's great. No, it actually can have lots of complications. Lots of complications when that milk is really distended. That milk has to go somewhere. Some women have lots of storage capacity and it doesn't cause a problem, but 45 ounces is a lot of milk in a day. How much does a baby at 3 months of age usually feed? Think about what the formula fed baby typically gets at 3 months of age. That's your ballpark. Very different for breastfed babies. But that ballpark is not 45 ounces, right? They're somewhere between, depending on the kid, 25 to 35 ounces a day, right? So 45 ounces is a lot. Her pain is primarily on the left side. And right now, with that discomfort that she's getting, she's only getting 28 ounces a day, most of it off of the opposite side, okay? So you mentioned massage. Not sure why that's not, oh, I think I just got a break. So this is what her breast looks like. It's red, it's in a streak. What does that tell you given the anatomy that we just looked at? Does that help you? Why? Why does it help? It's probably a low, right? So, and she's been pushing, trying to relieve it, and it is hard as can be. She is in tears because she's so uncomfortable. Here's a resource for you. This picture comes from the Physician's Guide to Breastfeeding.org, which is put together by Katrina Mitchell. She is a breast surgeon, breastfeeding medicine physician, as well as a perinatal mental health provider. And I think she's board certified in that now. I can't remember if she's finished that or not. She's fantastic, has a wealth of information, and has been so helpful in kind of building this field and getting lots of research going. So that research, that website is available to you. It has a ton of information on it. If you're looking for how to troubleshoot, there's more information than you know what to do. I haven't made it through the whole thing yet. It's that big. So there's been a change in the way that we manage mastitis. So first off, that's probably not mastitis. Whoa, right? A year ago, 2 years ago, every mom who had a red, sore breast was taught they had a mastitis and they were given antibiotics over the phone, not even seen, right? Told to massage the heck out of that, right? And keep emptying that breast like crazy. Well, that's the old news, and we've done a lot more research. Research has absolutely changed in the past 15 years, and some of that stems from, in 2011, the U.S. Surgeon General put out a call to action for breastfeeding, and with that came federal dollars to promote both research at the larger level, as well as to do some education, as well as interactions and laws in the community and the state protections for nursing, because this is a public health initiative. We know we can make a big difference in our society's health if we're giving them human milk, not cow's milk. Okay. So it used to be every redness, every pain was a mastitis, and we treat with antibiotics. Hot compresses to the breast and massage it like crazy because we want to push that blockage out. Turns out that didn't work so well. And lots of women were having recurrent mastitis. So the newer recommendations, and I've seen a huge improvement in this, is that hyperpigmentation, that redness that's there, is inflammation. Look at that duct. Look at those lobules, that line that she had. It's usually very localized. And what we're going to do first is ice. We're going to calm it down. We're going to use some ibuprofen to the site. And you just watch closely with this. So I do this every single week, not quite every day, where I'm talking moms through, put ice on there, do some ibuprofen, doing some gentle massage, and I mean like petting a cat, right? It's not very heavy that you're doing, and kind of, again, sweeping on the lateral side and up toward that subclavian vein. And we're feeding on demand. We're not pulling to empty. My goal is not to get to 45 ounces. My goal is to be an exact producer. We can have a little bit in the store, in the freezer, but not huge volumes. And direct feeding on demand, because we want to pull it and keep it moving so that we can maintain that supply, but we don't want to cause more trauma. This mom had never latched, good point. So I helped her latch that baby in the office, more for pain control. And by the time she left, she was happy and smiling because her breast didn't feel so full and engorged. And the baby ate so much because they could get it and pull it faster. And we did, she still wanted to exclusively pump, but we worked for her on how to make her pumping more effective, decreasing her oversupply, and always doing a little bit of some time at the breast for the baby to be able to help with that feedback loop, as well as to empty better, because the baby with a good latch should transfer and relieve that pressure in the breast better than the pump. There's a great handout. This is from the Anatomy of Breastfeeding Medicine. The Anatomy of Breastfeeding Medicine has built several of these. This one is free as a download. You can print it and give it out to patients. You can also order them in color. And it goes through what to do specifically so that they can take it home. Because what they're seeing on TikTok and Instagram and all their friends is heat and massage like crazy, right? The toothbrush on that area, right? So if you've got a swollen ankle, you sprained your knee, do you really want to push it? Do you really want to put a toothbrush on there and vibrate that thing? They sell these different products that will do exactly that, but we want to calm that down. We want to get rid of that inflammation. And then the prevention is pulling just enough with a good removal. All right, so hyperlactation, I would much rather have someone be an exact producer. And underproduction, while it's stressful for the families, is hard, but the complications of hyperlactation can be big for both mom and baby. Babies who are, because we're pediatricians, we're gonna do that first, they can gain weight really fast. Like 2 ounces a day is a lot, right, for the baby under a month. They have trouble getting on sometimes with that deep latch because of a couple things. They are, if the breast is engorged, they can't get on deeply, and so there can be trauma to the nipple for mom. They can also have super short feedings because it comes so fast, they'll choke and gag at the breast, pulling on and off and on and off and on and off, which causes trauma as well. But they're trying to get comfortable, they can't manage that flow. They can also have symptoms of explosive stools. A lot of times if those stools are light green and frothy, oh, I know we're not getting enough of that good hind milk that's coming in later. The fat content increases the longer they feed. Choking at the breast. And some kids will just flat out refuse to go to the breast because it's so uncomfortable for them trying to manage the flow. If you've ever had somebody squirt water in your mouth when you're drinking, it's uncomfortable, right? Mom can have really big breast growth, which can be uncomfortable, swelling that goes along with it, and then that fullness and pain that goes along with it. Recurrent ducts and mastitis. You can have nipple blebs that are trauma related because of the on and off at the breast with an insufficient latch, and vasospasm, which is really hard to manage. Vasospasm is in reaction to the trauma at the breast, and they can have some clamping down of the nipple. It gets really uncomfortable. It's almost like Raynaud's of the breast. And pump trauma. For moms who are exclusively pumping, it's a lot of work. Quite frankly, for moms who are only pumping when they're at work, it's a lot of work. And so we want to make sure that it's a good fit, like several of you mentioned. We want to make sure that the frequency is enough. Longer periods in between can interfere with the volume, but also the distension. If we're not emptying enough, that can really cause a problem. And the other part is the suction. Most of the newer pumps have a couple different things. They will, you can usually adjust both the amplitude, how big of a suction it is, and the frequency of that pull. And you want to get to the place where you have milk removed comfortably. Some women, and I've done this myself, I got 7 minutes and I got another patient and I got to do all this stuff and I crank up that suction. I'm going to make this happen faster. And all that does is causes trauma inside of those ducts, right? And so if those moms are trying to get through as much as they can, or the fit isn't well, they'll have more of those complications, okay? The other thing that's worth noting is that the reason, well, moms who are exclusively pumping tend to have more trauma to the breast in general because the pumps do not work the way that the baby works to remove that milk. The pump is all on or all off. So you always have a much bigger amplitude of pull, right? So it's barotrauma. Versus if you have a baby at the breast, they maintain a little bit of suction on there, and so the amplitude is less. And we think that's why they pull a little bit better. There's less trauma to the duct and the alveoli itself. Okay. Lots of resources for nipple pain. Okay. Most of these, all of these come from the Anatomy and Breastfeeding Medicine. There's protocols on there to help you differentiate between the nipple pain, right? Is this pure and simple baby sucked a hickey on the nipple and that hurts? Or is this vasospasm, and how do you manage with that? The mastitis spectrum goes through a lot of the research that has been put in place to kind of manage these changes, as well as looking at what does this look like long term. Dr. Katrina Mitchell was integral in kind of putting that together, and she talks about the highway because that's her frame of reference in California. And hyperlactation, right? It does have issues that we want to make sure that we are managing. We don't want the freezer store. There are some women who are just naturally overproducers, but we don't want that to be the case because it can cause lots of issues. Any questions before we move on to the next one?
I have a question, but I don't know if it's relevant at this point or if I should ask it at the end of the lecture.
Why don't you wait until the end so I can make sure I get through everything. This is our last case.
Okay.
So I'm hoping that we'll have some time at the end where we can talk. Oh, no. I've got like 2 minutes. Okay, here's a quick one. This is very appropriate for the nursing moms, especially in the hospital. Professional women have the hardest time being able to pump at work. Okay? So she is a 10-week-old who is exclusively breastfed. Mom's this is her third baby, and she has exclusively breastfed her babies with providing pumped breast milk while she went back to work. She stayed out the longest with a little bit of some difficulties in the beginning, but really went downhill when she started to daycare, and she flat out refused. There's growth. Are you worried about that? I will tell you, I wasn't super worried in the very beginning, because mom and dad and 2 brothers are all on this like 5th to 10th percentile. So we were watching closely, and about the 2-month mark is when she really started to slow down, right? So ideally, we're going to return to work and practice and start building a store about 2 weeks before we go back to work, not before. The milk looks really different at 2 weeks and 2 months and 12 months. So we want to give baby appropriately aged milk. But offering a bottle about 3 to 4 weeks of age. And that is so that we can get through that first stage of that lactogenesis. We established our breast milk supply, and we're at a good space. Baby knows how to latch and transfer well, and then we offer opportunities to practice. And whoever's going to be the person who is giving the bottle is ideal. You're not going to take them to the daycare to give it, but it's not mom, ideally, to be able to give that bottle. And again, we've talked through the fit and pumping and the flanges, as well as matching the feeding schedule for mom. Supplement options are out there on that protocols, and also strategies in returning to work, which are really helpful, especially in the hospital, you guys. It's hard to be able to take 15 minutes 3 times a day. It sounds silly, but 15 minutes is a lot when it adds up to 10% of your time in the hospital for the day. You're having to do it 3 times. I would encourage everyone to support one another. There's ways that you can do this around here, and there are lots of new strategies now. The OBs, there was a OB that would walk into her 8-hour case and put her flanges on. She had the hands-free pumps. She could turn it on under the sterile field, and she would wait her 2 to 3 hours until she felt like it was time to go, turn hers on, and then take a break and swap them out so that she was ready for the next time for her 8-hour case. There are ways to do it, but it takes a lot of planning. And the Carilion has a great program to be able to help and give opportunities. So help one another out. It's for both mom and baby's long-term health. Going back to the Surgeon General's call to action, a lot of the laws that have been put into place, and then recently in 2023, the Pump Act was put into place. It gives employers very specific instructions on what they're required to provide. They have to provide employees a place to pump, not a bathroom that's private. They also have to you're entitled to be able to have that time to pump. Every employer does a little bit of some variations on there. And some industries are exempt. The one that I was like, oh, well, that makes total sense that you're exempt with that was flight attendants, right? There's no private place for them to go. So I have linked on here the Department of Labor instructions so that you can empower your patients, because they still will get impact back from their employers at times. For this mom, for this baby who refused a bottle, usually trying the nipples, the different nipple bottles, doesn't make an impact. Some kids do. Some kids finally say, okay, fine, and they'll do it. But being able to feed that baby while you're gone is important. So cup feeding is a great way to do it. A lot of times I'll tell them to get a sippy cup and take the valve out, and they can pour it in their mouth like that. Not cradling the baby and instead having the baby in front, like in a car seat or a swing. Sometimes having the baby sit in the lap facing outward and feed like this can be a good help. Reverse cycling, which is where they sleep all day and feed all night. I had a kid who did that. It was awful. And then creative work scheduling. This mom she's a professional, she ended up saying to her boss, I'll be here for 4 hours in the morning and I'll be back when my baby can have food, which is not easy. And happy National Breastfeeding Month, which is the month of August. A couple other resources for you. The Virginia chapter of the AAP is working tirelessly for the pediatricians in the area. Related to our topic, Dr. Karen Bodner and myself are the two breastfeeding co-champions in the area, and we work diligently behind the scenes to help educate as well as to advocate, working at the legislative efforts with the advocacy team for the Virginia chapter. And we are both willing to help. If there's issues or concerns, don't hesitate. That's my office number and my email. I don't always check my email every single day, so if you need something, feel free to reach out to me, and I'm happy to talk to you afterwards if you would like. And Dr. Karen Bodner is in Northern Virginia. There are several breastfeeding medicine physicians around the state. I just happen to be the only one west of Charlottesville that I know of. And in ANOVA at King's Daughters, at UVA, and at VCU, there are multiple there as well. And I would be remiss if I did not put in a plug for the Virginia chapter of pediatrics, who's working on multiple things that are much bigger than each of us individually, looking for billing. How do we get paid for the work that we do? How do we advocate for physicians? How do we help with mental health? How do we help with sports physicals and all those details on the state level?